Welcome to the Researched RN podcast. I am your host, Stephen Kuzmenko. In this podcast, I discuss new and interesting peer-reviewed research articles from various nursing researchers and other professional publications. In this 15th episode, I'll talk about an article published in the March 2025 edition of BMC Nursing, that's Biomed Central Nursing, titled Nursing Contribution to End-of-Life Care Decision-Making in Patients with Neurological Diseases on an Acute Hospital Ward, Documentation of Signs and Symptoms. It's authored by Johnsdottir and colleagues. It's just going to be me this time. I hope you guys enjoyed the last episode. I had some guests on for the first time. I am working on lining up future guests for upcoming episodes, so stay tuned. But today, you just have me to listen to. I chose this article because my top listening episode is pertaining to end-of-life communication and how nurses can do that. And so I really wanted to see if that's content that you guys are looking for and need, whether it's your professional development or you actually use it in the workplace. So I wanted to pick an article related to end-of-life care and specifically how nurses can contribute to that process for our patients. So that kind of brings us into the intro. Why is this important? Recognizing imminent death, it's a fundamental skill for nurses and other healthcare professionals. It's important that we recognize that so we know, A, are they full code? Do we need to escalate? I need to detect that now and communicate that now. Or are they closer to end of life and I'm seeing that progress, that process advance, and I need to treat them so that they're comfortable. And it's important that we can recognize signs of impending death for the reasons that I just mentioned, also because it leads into end-of-life decision-making or discussion. So we see these ominous signs. We don't think that this person will survive, but we want that person to be comfortable, but we need to have those conversations. And a lot of times people are kind of drawn away from wanting to talk about that. Of course, they want their family member, their loved one to stay, and they don't want them to go. So why would they want to talk about the end of their life? It's a challenging thing, and the authors of this article definitely mention that, how challenging it is. But those are some of the main reasons why this is important for nursing practice, but also the challenge that exists in neuro patients. So, I mean, in some people, detecting signs of imminent death can be hard, but if they have a baseline neurological disease, it can be even harder. And that, of course, demands some sort of attention, because if those folks need end of life decision making and it's hard to detect those signs because their baseline is already so altered, well, we want to alleviate suffering as much as possible. So, how do we do that? Failure to recognize end-of-life care can prolong suffering. As I just kind of mentioned, it adds stress not only to the caregivers, of course, to the patient, but to the nurses that are caring for that person and the healthcare team in general, as well as the nurses. It can cause stress in them, and it delays palliative care, decision-making, ultimately prolongs suffering. And the authors of this article note an interesting fact that I like that they mentioned was that end-of-life decisions occurred sooner after hospitalization in patients that had acute neurological conditions compared to progressive neurological conditions. This is still in the background, the intro. This is not part of their study. They did a previous study, though, and they found that for patients that left the hospital after stroke, hemorrhagic, or ischemic, the median time to end-of-life decision or palliative care was 4 days. And with progressive diseases like ALS, amyotrophic lateral sclerosis, and Parkinson's or extrapyramidal and movement disorders, that median time was 9 days for ALS and up to 22 days for Parkinson's or extrapyramidal and movement disorders. So that's obviously quite a long time. These signs and symptoms that exist in neurological patients that, they can signify terminal disease can be things such as excessive sleepiness, bedbound state, progressive weakness, decreased urine output, dysphagia with a G. So that has to do with eating, delirium, decreased level of consciousness, noisy respiration or excessive respiratory tract secretions, dyspnea, changes in their breathing patterns. So this can be Cheyne-Stokes respirations that also include periods of apnea, modeling and cooling of the extremities. Those can be ominous signs of, in general, patients that are experiencing imminent death. But it's not a one size fits all. When it comes to neurological diseases, the authors note that you do need to know the trajectory of the disease. And what they mean by that is immobility, bedbound, and dependent state. Generally, those are not good indicators, especially if you see them develop and evolve over time. This is getting worse. That can be a sign of imminent death. But in ALS, amyotrophic lateral sclerosis, this can actually occur for a long period of time, potentially months and maybe even years. So in that disease, that's normal. That's not a sign of death. Independence with talking and eating can occur just hours before death with ALS. So unfortunately, yes, those signs and symptoms are pretty ominous. They're not great. But for ALS, it's not a sign of imminent death. And another example can be in stroke, paralysis and immobility. That is normal signs actually of a stroke. You'd expect to find that, depending on the severity of the stroke, of course. But people can live many years after having a stroke. Some people can even walk decently well. Of course, some can't, and it's complete paralysis. But that would not necessarily be a sign of imminent death. And so really what's left for neuro patients that's frequently assessed is level of consciousness. But even these are not great indicators because they can fluctuate based on medical condition. Maybe they're experiencing infection or they're ill, uh, or they've taken medications that can alter their level of consciousness, given potentially pain medicines or anti-anxiety medicines. Those can obviously fluctuate or cause fluctuations in level of consciousness. So of course there's a need here, and that's kind of what the authors try to paint this picture in the justification for their study. They do note that in cancer patients there actually is guidelines that are created for recognizing death, kind of these set signs and symptoms, but unfortunately in neuro patients that has yet to be determined. And so this study, the aim was, quote, to describe nursing contributions to end-of-life care decision-making and compare signs and symptoms of imminent death in patients with acute versus progressive neurological diseases during the final 3 to 7 days of life. So kind of two aims of this study. Leading into the study design, the purpose, and some of the methods, the setting. This was a single center study that took place at a university hospital in Iceland. Actually, the hospital that this took place in, it was a neurological ward. It's Iceland's only specialized acute neurological ward or unit, at least at the time of this podcast. That's what they mentioned in their article. All the nurses in this unit had a BSN, and the patient ratio is 1 to 5 to 7, 5 to 7 patients per nurse. The methods, how they answered this question, they did a retrospective review of patient records between 2011 and 2020. And they looked specifically at the documentation of end-of-life care decision-making, signs and symptoms that were indicative of impending death, and how end-of-life care was communicated with patients and caregivers, of course, in the last 3 to 7 days of life. Patients were included in this retrospective review if they were 18 years or older, and if they were admitted to the neurological unit with the following diagnoses: ischemic or hemorrhagic stroke, Parkinson's disease, ALS, and extrapyramidal and movement disorders. They were not included if they had any other diagnosis, if their hospital stay was brief. They don't really define that. I'm guessing less than 3 days. They weren't in the hospital very long, or they had minimal documentation. The records that they looked at, there were 271 total patients, and the final analysis, they looked at 209 patient records between January 2011 and August 2020. Looking at the documentation parameters that I just mentioned. And then they also looked at specifically how nurses' role in end-of-life care decision-making occurred. So That was different though. They looked at that between January 2017 and August 2020. So nonetheless, they looked at signs and symptoms that were indicative of death, end of life care decision making, how this end of life care was communicated, and they looked at the nurse's role in end of life care decision making. They used a tool that they had developed. It's called the Neurological End of Life Care Assessment Tool. It's 32 items. This tool looked at healthcare professionals' contribution to end of life care, looked at documentation of end of life care decision making, signs and symptoms of potential impending death, and communication with relatives or caregivers. Those were kind of the four main domains they looked at for how nurses' contribution to end of life care took place. The instrument there, they used the guidelines from the Registered Nurses Association of Ontario and then other findings in the scientific literature that point out three main roles of nurses that have been previously mentioned. Those three roles are information broker, which it has to do with clear and timely information of treatment and plan. So kind of like I think of it like that the interpreter, like the medical interpreter, they hear these big words, these medical terms, and boil that down to lay terms. What does this actually mean? The second one was advocate. So this ensures that the patient's wishes are respected. The third one was supporter. So this has to do with the help that's provided with coping with the challenges that come with the end of life process. So they had this end of life care assessment tool, and they looked at the nurse's contribution to end of life care using those three roles. And here are the findings. So of the 209 patients, most had the diagnosis of ischemic stroke, 123. Second most were hemorrhagic stroke, 48. ALS was the third with 27, and Parkinson's disease with extrapyramidal movement disorders was 11, the least amount there. The average age of all the patients, this cohort at the time of death, was 79. Most of the patients in this sample were women and married and or lived with another person, so they cohabitated with someone else. The progression of disease was recognized in the vast majority of cases, 94%, and this documentation broke out between nurses and physicians. Physicians recognized it in the majority of cases, 79% of the cases, but nurses recognized progression in 44% of cases. So almost half of the cases, the nurse was the one that recognized the progression of disease. The need for end of life care was documented in the vast majority of cases, 85%. And nurses' contribution end of life care decision making, this is where it gets broken down, nurses and physicians. 36% of cases, nurses contributed to end of life care decision making in general. And so I'll get to those three roles that they were acting as, the information broker, advocate, and supporter, but that tells you over a third of the cases that nurses were involved. And then physicians, the majority there, 76%. The nurses contributed to end of life care most in ALS diagnoses and the least amount in Parkinson's diseases. And stroke was kind of in between those two. Nurses, as far as the three roles that I just mentioned, nurses most frequently acted as information brokers. So between information broker, advocate, and supporter, information broker. And within that, they were most commonly communicating the signs and symptoms of impending death and the overall need for end of life care. I mean, how reflective of current practice is that? We are kind of the translator for the physician and the patient, usually communicating to the patient, this is what we just talked about. Does it make sense to you? Because we're there more often. We're there, all day. We spend the most time with the patient. So we have the time and the rapport, the relationship to be able to do that. As far as how nurses communicated, there was a really nice quote that they pulled from the records that show the nurses, argumentation is the word that they use for the need for transition end of life care. Whether or not that's an appropriate term, that might be for you to decide, but I don't necessarily think that we argue for the need. Maybe that comes down to it in some situations or some settings you may or may not have experienced. I think it's more so we advocate for it. But nonetheless, the quote that I think really reflects kind of embodies all of this was a patient that had a stroke. The nurse said, quote, "The patient seems to be close to dying, but the family is struggling to accept how advanced the disease is. It would be helpful if the physician talks with them again tomorrow and considers adding midazolam PRN alongside diazepam and morphine. The dyspnea episodes were difficult for the patient last night. It would have been better for her to receive midazolam rather than repeated suctioning. The patient's adult children do not realize the severity of her condition," end quote. I think that quote really does kind of embody all of the things that nurses do and how they really do contribute to the end of life process. I think that even in those few sentences that I just read, you can see elements of all three of those roles: information broker, advocate, and supporter. You can see all of those roles just in that little excerpt. So those are kind of the main key findings that have to do with nurses' contribution to end of life care. This second part here that they talk about really goes down to the signs and symptoms by disease type, which is acute disease processes and then progressive. So acute being stroke, progressive ALS and Parkinson's. I'm going to give a high level overview because they really go down to the nitty gritty about the exact percentages of about 20 different symptoms for each of the diseases. And then they also break it down even further on whether or not the patients had end of life care decisions already made and what symptoms they had, and if they did not have end of life decisions already made and what symptoms they had. So I'll give a high level overview. And if you're very interested, if you work with these types of patients, you work in palliative care, I definitely encourage you to read this article, and you can really see the specific occurrences of these symptoms broken down by disease type and end of life care status. So in general, documentation patterns varied, and of course that makes sense. Not everyone doesn't document the same. Acute conditions in general, like stroke, had more immediate and frequent documentation than progressive symptoms. The average number of signs and symptoms for the entire sample was 6.5. The range was 1. So I guess there were patients that only had one sign and symptom of impending death documented, up to 14 signs and symptoms of impending death. That is a lot. As I mentioned a little bit ago, whether or not they had an end of life decision already made, the patients broken down between the two, there wasn't really a big difference in the number of signs and symptoms that were documented, except for those with hemorrhagic stroke. So patients with hemorrhagic stroke that had end of life care decisions already made, meaning palliative care in place, they had an average of 7.2 signs and symptoms. And if they did not have end of life decisions already made, they had an average of 4 symptoms. So, I mean, that's pretty significant. And with a hemorrhagic stroke, as I mentioned a little bit ago, they found that the acute conditions had more immediate and frequent documentation. I mean, hemorrhagic stroke of, probably the most noticeable signs and symptoms and the most rapidly evolving condition that you can maybe take care of in general. So it's no surprise, I guess, in my opinion, that they had the most. But I think it's interesting how that diagnosis was the only one that was statistically significant in the difference in the number of signs and symptoms that were documented. The other diagnoses, they were pretty much equal, whether or not they had end of life decisions documented. And one of the things that they mention is, well, why did these progressive diseases have less signs symptoms documented of impending death? And they kind of talk about how the signs of these diseases, ALS and Parkinson's, they're more gradual, and things like fatigue and dyspnea being the most common. So, as the fatigue and dyspnea gets 1% worse each day, it's hard to recognize that unless you see them one day and then a month later you see them. But if you're that person going in every single day or even multiple times a week, as kind of the standard shift change that occurs in nursing, it's hard for you to detect those. And so, of course, how do you have to find those symptoms, and you have to communicate that and say, hey, we need to get this end of life care. This is impending death. But it's harder to detect those in those progressive diseases because, those diseases do, they don't quite have as rapid of a mortality or a death process than, say, hemorrhagic stroke, for example. Another thing that was interesting about the difference between acute and progressive stroke patients that had end of life care in place, non-responsive communication was the most frequent sign and symptom that was documented. So they are not talking. Okay, that was kind of a red flag. But then when you look at ALS and PD, Parkinson's, with end of life care decisions made, non responsive communication was actually the less frequent. So they both have end of life care decision making, but stroke patients don't talk as much. And that is a concern. Whereas ALS patients talk normally, right? Leading up to death. So of course those progressive diseases are really challenging, but they're still talking to you. So it's even that's another reason why it's so hard to say, yeah, they are dying. They're going to die in the next within a week. They won't be alive, but they're still talking to you up until hours before they die. Now, I will say that the ALS fact that I mentioned with the non-responsive communication being less frequent in patients that had end-of-life care decisions, that was not statistically significant, but it was at least a noticeable difference in the numbers. So the last kind of main finding, we talked about the key findings being nursing contribution end-of-life care. The second bucket of key findings was the differences in signs and symptoms. This last bucket of key findings has to do with communication. So how were family members, caregivers, relatives is the word that they use in the article. How were these findings, the signs, symptoms, and this impending death communicated? So end of life care conversations, at least informal end of life care conversations with patients, ranged from 4 to 63% of cases. And it was more frequent in patients with ALS and less common in patients with hemorrhagic stroke. Informal conversations with relatives, on the other hand, was 73 to 87%. So a lot more conversations happening with family and caregivers or relatives than with the patients directly. Now, this is probably because the patients aren't doing well. They're not breathing well. They're coughing on their or choking on their own secretions, or they're not communicating. Particularly, it's no surprise that was less common with patients with hemorrhagic stroke. They're probably not able to talk. They're probably not very awake. Their level of consciousness is probably deteriorating somewhat rapidly. So of course, because again, all of this data is based on documentation. This is a retrospective analysis. So they probably were not, maybe they were communicating or at least trying to talk to the patient, but maybe it wasn't, the clinician maybe didn't think that was meaningful enough or significant enough to be documented, that they said something or did something with the patient, particularly with hemorrhagic stroke. So I think that that's a pretty interesting finding there. But formal family meetings happened 82 to 96% of the time. So the vast majority of these cases, they had formal family meetings to arrange goal clarification, emotional support processing, that information broker. They're communicating, what does this sign symptoms actually mean? So I think that's where those were happening. And it's good to see that they were happening very frequently. And so those are kind of the main three buckets. Now we can move into the discussion and the implications for nursing practice. So from this article, we see that nurses play an essential role in recognizing imminent death and how these are communicated to the provider, to the patient, to the family, and to the caregiver. Ultimately, recognition of imminent death leads to end-of-life care decision-making. The average signs and symptoms for this sample was 6.5. They had 6 symptoms on average, but that range was quite big, 1 to 14. And of course, I mentioned earlier, the highest signs symptoms were in hemorrhagic stroke patients. And it makes sense. I mean, this is an acute process, rapidly changing clinical status. And they do mention that in general, the acute diagnoses had more thorough, more detailed documentation. There was a different study that they outlined, that they mentioned, that had 12 signs and symptoms of imminent death that were kind of used as a protocol. Now, that wasn't the point of this study. And that other study that they mentioned they were not in neuro patients. It was just in general imminent death. And the authors bring that up because, of course, it's good to relate work to other work, but they had 7 out of the 12 were acceptably documented in this study. So again, the point of what they're trying to do in this is to develop guidelines, protocols for detecting imminent death in neurological patients. So it's really good to relate it to other work that's similar, even though it's not necessarily neuro patients. I like that this study looked at what nurses and providers felt needed to be documented with no predefined signs and symptoms. So it's like seeing patient care untouched. How is it naturally occurring in the workplace? And so what would be interesting to see is, of course, this study, this type of information obtained from other sites, from other acute neurological units elsewhere in the world. Is it similar? I mentioned that informal conversations happen more frequently in ALS than in hemorrhagic stroke. It's probably due to the less responsiveness that occurs in stroke, particularly hemorrhagic stroke. Now, it's not to say that, we should not be having conversations or at least attempting to speak to someone who's experiencing a hemorrhagic stroke. Now, if they're sedated and intubated, you're not going to expect a response back, but it doesn't necessarily mean you cannot speak to them. They can potentially still hear you. So I still think that, even though informal conversations didn't happen as often compared to family and caregivers, it's still important to speak to our patients with what our findings are and with the care plan, because that's what we're doing to them. Okay. In general, the authors do note this lack of end of life communication guidelines for patients with ALS, and they actually mention that as a study in general for progressive diseases. Like, how do we communicate with these folks? They are able to talk, as I mentioned. Nonverbal communication was documented less frequently in the last 7 days of life compared to acute conditions. So patients with ALS and Parkinson's are talking in their last days of life. So how do you communicate that to them? Is that, there should be guidelines made for clinicians, particularly, younger or inexperienced in this kind of setting. That would be helpful, I think. And so some of the implications for nursing practice, I think hopefully you can pull from this. It's important that we have early end of life conversations. It might be important. The authors potentially bring up that maybe having competencies how to do end of life communication or discussions in nurses is needed, particularly education on neurospecific end of life. So what are the differences in acute conditions that compared to progressive conditions that both signify imminent death, but they look very different based on the disease pathway? So maybe that's something that could be in place if this kind of thing is something you experience often. Maybe having education on these pathways and what they look like towards the end of life is important, where you actually do look at the frequencies of the signs and symptoms based on the specific diagnosis that information I did not speak on explicitly. That might be something you need to look at. But in general, hopefully this article shows that we need better symptom detection and documentation to improve communication to the provider. So not only is it that we need to detect it and document it, but we need to then communicate that to the provider, knowing the disease state, knowing their clinical condition, all of that. The author suggests that there should be more exploration on what contributes to the delayed recognition of imminent death. That's not something that they talked about here. They didn't look at timing, but it could be something that's occurring. I'm sure it is in acute care settings, particularly if these signs and symptoms are mistaken for acute reversible symptoms, when they are in fact signs of imminent death. The limitations, there's a few here that we need to just be aware of. This is a single study. It's a single center as well study, so it's not multi-center, and that just makes it harder to apply the findings to other places. This is in Iceland. This is probably really good for neurological patients in Iceland, but is it really good for neurological patients in Mexico, in Washington State, in Australia? So those kinds of things we need to keep in mind. Retrospective analysis, the study design can overlook certain details on the care plan or signs and symptoms because they're documenting what they think is important. So again, they mentioned the education and how timely is this documented. That information was not looked at specifically, but this was a retrospective analysis, so we have to keep that in mind. We're not seeing that information, and in general, this information was 100% dependent on what was documented, which varies amongst nurses and providers. Not every nurse, not every provider documents the same way. So again, having guidelines, protocols, which is what they really advocate for in the conclusion, that would help, right? Final thoughts. I hope that you see that nurses are the bridge between families, patients, and providers. I hope you see that early recognition and advocacy for our patients can reduce suffering and ensure that the care we provide is aligned with patients' wishes. And then hopefully you can also see the need for stronger protocols in this setting, in end-of-life communication or end-of-life decision-making with neurological patients, and maybe even justify more training that is related to this. And that is a wrap on the 15th episode of the Researched RN podcast, your virtual journal club on the go. I am your host, Steven Kuzmenko. I'll have new episodes out at least monthly. You can email me at researchedrnpodcast@gmail.com with any articles or topics you'd like for me to discuss, and also connect with me on LinkedIn. If you enjoyed today's episode, please share with a friend, and it would also be a huge help if you gave me a positive rating so others can find me. Thanks for listening, and be sure to tune in to the next episode.